Hi, very good morning. I'm Dr. Janak Patel, MD, General Physician. All my video lectures are mainly for educative purpose in continuity with the previous lectures in neurology or we call nervous system examination. Today we'll be dealing with one of the very useful topic, that is examination of vagus nerve or 10th cranial nerve. We have already done major part of examination in while doing an examination of glossopharyngeal. Vagus nerve is a very long nerve. It is also labeled as wanderer nerve, or we call 10th cranial nerve or vagus nerve, and it supplies large number of different viscera. Usually we don't go for the examination of those visceral functions, but there are some portion which we can easily examine, so we'll be dealing with that particular part. You can see here there are different names given: nervus vagus, 10th cranial nerve, as well as it is also called as wandering nerve. It arises from pons, not ideally pons, it is the upper part of the medulla. After coming out from jugular foramen along with the 9th and 11th cranial nerve, it will have multiple branches, which a very long branch which goes down supplies heart, lungs, esophagus, stomach, spleen, kidney, liver, gallbladder, and even small intestine and colon. So these are all the structure which it supplies. But we'll be dealing with some of the portion which is very easy to examine. So it will be supplying all these viscera: heart, lung, liver, spleen, kidney, stomach, esophagus, etc., and even small intestine as well as colon. But to some of the organs what it supplies, that is pharyngeal muscles, larynx, those we do examination. So we'll be going through that particular part. We call this as a parasympathetic nervous system, and parasympathetic supply to eye, lacrimal glands, lung, heart, stomach, pancreas, small intestine, etc. We have got parasympathetic supply, and lower part of the spinal cord will be supplying parasympathetic part to colon, rectum, bladder, etc. So we'll be dealing mainly with some of the portion which is easy to examine. I'm skipping all these slides. This is a difference between parasympathetic and sympathetic supply. What are the organs and what will be the difference between sympathetic stimulation and parasympathetic? That is, vagus nerve does not supply iris, salivary gland, but it will supply heart. So as far as vagus nerve is concerned, it will reduce the heart rate and it will reduce the force of contraction. In a lung, it will give rise to bronchial muscle contraction, while sympathetic will give rise to relaxation. It will increase the gastric juice and motility will be increased by parasympathetic. In kidney, it will increase the urine formation, and in bladder, it will give rise to contraction of the detrusal muscle, and internal sphincter will be relaxed, and it will increase the act of micturition. So this is a peculiar action which will be done, but this particular part, bladder, will not be supplied by vagus nerve, but it will be supplied by sacral segment parasympathetic part. So this is the main slide. We'll be taking a little longer time to explain all those things. Vagus nerve is arising from 4th and 6th arch. We are not going into that particular part. This is the entire supply of the vagus nerve, all the different parts, right from we call arch of aorta where it is supplying the aortic body, aortic receptors, etc. Will be going through those particular portion in this side. So parasympathetic supply cardiac branches and also to the thorax and abdomen. Visceral sensory to thorax and abdomen. Taste sensation also to a posterior part of the tongue and little portion of the pharynx also, little behind the tongue, and baroreceptor and chemoreceptors. While it will be supplying a bronchiomotor fibers to muscles of pharynx, muscles of larynx, soft palate and upper part of the esophagus. As well as there is a sensory portion also to larynx, laryngopharynx, posterior part of the tongue, that is not posterior 1/3 but posterior to the tongue, external auditory meatus and even eardrum and little behind the ear. So if we look in this particular portion, what we are going to check is mentioned here. We call somatic sensory or general sensory, not ideally somatic sensory but general sensory. One auricular branch which will be supplying external auditory canal. Then we have got another branch which is internal branch which will be supplying tympanic membrane, eardrum and external auditory meatus. And then we have got a recurrent laryngeal nerve which will be supplying laryngeal part sensory, laryngopharynx, as well as little portion behind the tongue. And this recurrent laryngeal nerve will be also supplying all intrinsic muscles of larynx. That is, we call all the muscles included in vocal cords, etc. So this will be the portion. So visceral sensory, general sensory. Visceral sensory will be to say sensory part to and also for the taste sensation. Then bronchiomotor will be supplying pharyngeal muscles, cricoid thyroid muscle and intrinsic muscle of the larynx. And this particular, that is parasympathetic fiber, will be supplying to cardiac, that is myocardium, particularly SA node and little structure of the heart. There will be one group of fibers which we call concerned with visceral sensory, but they are concerned with baroreflex and chemoreflex. That is called baroreceptors and chemoreceptors. And this will be aortic body, it will be supplying. So this will be the different supply of the vagus nerve. This is the posterior view. So this particular portion is called nucleus ambiguous. Nucleus ambiguous. Then we have got the dorsal vagus nucleus, that is this blue color. And this red color is called solitary nucleus, and that this green color is spinal nucleus of trigeminal nerve. So it will be supplying the somatic sensory type of fibers to transmit the sensation from external ear canal and eardrum. Visceral sensory will be to abdominal viscera, thoracic organs and cervical. And spatial sensory, that is taste sensation, to posterior 1/3 of the tongue and also posterior part of the tongue. Bronchiomotor to one muscle, that is stylopharyngeus muscle, muscles of larynx, that is by a recurrent laryngeal nerve, and also the muscles of pharynx and upper part of esophagus, and parasympathetic fiber to cardiac muscles, to the smooth muscles of trachea and bronchus, then also to the glandular structures of thorax and abdominal viscera. And that's why it is also called as a wandering nerve. It is a very big area of supply. So it will be carrying the information of about pain, touch, temperature from throat, inner and outer part of ear, little amount of meninges, and just behind the ear. It plays a very minor role as far as in a taste sensation is concerned. It will carry the taste sensation from epiglottis and the portion behind the tongue, we call the root of the tongue. It receives the sensory information from internal organs in the neck, chest and abdomen. This will be visceral sensory. It carries the sensory information from baroreceptor and chemoreceptor in aorta as well as aortic body. And it plays part in a baroreflex and chemoreflex. It also supplies the muscles of pharynx, soft palate, larynx. So it plays a very important part in sound production as it supplies the laryngeal muscles, particularly vocal cord muscles. So it takes part in production of the sound, and by supplying the pharyngeal muscles and little amount of soft palate, it helps in articulation as well as it helps in swallowing reflex. And it is a big parasympathetic nerve supply to multiple organs, right from upper part of the neck, esophagus, stomach, small intestine, duodenum, even ileocecal junction and ascending colon, as well as liver, spleen, gallbladder, pancreas. All these organs are having parasympathetic control. So if we leave apart these organs, now we'll be dealing mainly with function of larynx, soft palate, etc. So sensory supply to pharynx and larynx, motor supply to pharynx, larynx, palate, and parasympathetic supply to thoracic organ and abdominal organ. So this particular portion we have already tested in a glossopharyngeal nerve. That is, you ask the person to open the oral cavity and just pronounce ah. Now as soon as the person opens the oral cavity, breathes or he coughs or he pronounces ah, there will be lift of the soft palate. Along with the lift, you will see the arches are moving equally and symmetrical, and uvula is in the center. Now this is done by glossopharyngeal as well as vagus. And also when you do a gag reflex, the motor pathway is vagus. So that will be a part of vagus nerve, and sensory pathway will be by glossopharyngeal nerve. So these two will be the most important test which will be important. And then last we ask the person to swallow. So that portion can be also checked. And then you look at the movement of the larynx, that is vocal cord. So when you ask the person, if there is a deviation, it will be always towards the strong side. So if the uvula deviates to the one side and opposite side arch is flat, so side where it deviates is normal, and side where the arch is flat and uvula deviates to the opposite side. Say here you can see that this side is flat. Here you can see the arch very nicely, and uvula is deviating towards normal side. So that is, this side is paralyzed, means right side there is a paralysis, and this is very common with glossopharyngeal nerve palsy. So vagus nerve is giving a sensory fiber to the mucous membrane of larynx, pharynx, soft palate, and also entire GI tract right up to 2/3 of the transverse colon. And motor fibers to laryngeal muscles, pharyngeal muscles, soft palate, as well as involuntary muscles of the heart, respiration, that is smooth muscles of trachea, bronchi, etc. And also all the smooth muscles of GI tract right up to two-thirds of the transverse column. So when you want to taste, we usually taste for sensory in the form of gag reflex. When you touch the palate and you touch the pharynx, portion of the soft palate is glossopharyngeal, while when you touch the pharyngeal wall, it is that particular portion is also supplied by 10th cranial nerve. So sensory pathway will become 10th cranial nerve. Center will be medulla and motor fiber will be 10th cranial nerve. And whenever you touch the soft palate, we call palatal reflex, which is one part of the gag reflex, where a good portion of the soft palate is supplied by glossopharyngeal. So sensory pathway becomes glossopharyngeal. Center will be medulla and upper part of medulla, and motor pathway will be vagus nerve. And you will be getting a uplift of soft palate along with contraction of the pharyngeal muscle, giving rise to gagging, and that we call as a gag reflex. So you will have to find out which pathway is being affected, whether it is sensory involvement, whether it is motor involvement, or whether it is involvement of the center. We call it a damage to medulla, upper part of medulla. So suppose if the person without any stimulus, when you ask him to cough, if pharyngeal wall is moving nicely, both sides, then we'll call vagus nerve is normal. And if the glossopharyngeal nerve you want to test, you ask the person to open the oral cavity and look at the arches. If both arches are equal and uvula in the center, by and large the glossopharyngeal nerve is also normal. So you look at the palatal reflex, you look at the swallowing test, and you do a laryngoscopy for looking at the vocal cord, and you look at the arch. So these are the different tests which will be dealing. So best important while talking to a person, and when person is answering, by looking at the quality of the voice, you can identify total aphonia or hoarseness of voice because of involvement of one side vocal cord. So you can look at the heart rate, because parasympathetic system stimulation will produce bradycardia. So if there is a severe tachycardia, it will indicate damage to the parasympathetic system. When you look at the laryngeal part, observe for the voice quality. If person is not able to pronounce any sound, we call that as aphonia. To differentiate from true aphonia from psychogeny, you will have to look direct or indirect laryngoscopy, and when the person is breathing, or when person is coughing, or when the person makes an attempt to produce some sound, you will look at the movement of the vocal cord. If there is a total absence of movement of the vocal cord, both vocal cords are open, and person do not have any movement of vocal cord, we'll call bilateral vagus nerve or bilateral recurrent laryngeal nerve palsy. And this person will have very frequently regurgitations, very common. But if there is a unilateral, regurgitation is common, and there will be peculiar sound we call as a hoarseness of voice. This you will be able to identify very nicely by direct and indirect laryngoscopy, and you look at the movement of vocal cord while coughing, when the person is pronouncing sound, or even when the person is taking a deep breath. Pharyngeal movement, directly you can throw the light, ask the person to open the oral cavity, push down the tongue with tongue depressor, throw the bright light on the pharyngeal wall, and ask the person to cough. If you see the movement of both side pharyngeal wall, means vagus nerve is working. So that is one very simple way, and you can go for a gag reflex by touching the pharyngeal wall, and that will be sensory pathway will be vagus, motor pathway will be also vagus, and center will be upper part of medulla. And when you ask the person to swallow a gulp of water, it is testing multiple different muscles. But as far as the glossopharyngeal nerve and vagus nerve is concerned, in glossopharyngeal, if person gets a nasal regurgitation, it is more in favor of glossopharyngeal nerve palsy. And if a person is finding a difficulty in swallowing, then also vagus nerve may be affected. And this will be one of the way of testing 9th and 10th cranial nerve. So, person with a vagus nerve damage can come with abnormal heart rate, particularly tachycardia, GI tract symptoms. He will come very frequently when the recurrent laryngeal nerve is affected, hoarseness of voice, difficulty in swallowing, gag reflex will be affected, particularly pharyngeal reflex will be affected, and also during palatal reflex, you will have diminished gag reflex or absent gag reflex because of motor pathway. And you will see deviation of uvula away from the side of the damage, means to the normal side, will be also seen in case of a vagus nerve damage, because the part of the soft palate is also supplied by soft palate muscle is supplied by vagus nerve. This particular vagus nerve will be affected very frequently in a brainstem lesion, particularly upper part of the pons, medulla. Also, sometimes extramedullary lesion can produce a compression of the vagus nerve and can damage vagus nerve. Also, vagus nerve can be damaged in a jugular foramen. And whenever you get a bulbar palsy due to involvement by different disease, particularly like poliomyelitis, syringobulbia, motor neuron disease, Guillain-Barré syndrome, you will have involvement of the vagus nerve along with other cranial nerves, and that will be motor involvement. Also, you can get involvement because of syringobulbia, posterior fossa tumor. You can also have a vagus nerve involvement in advanced Parkinsonism. Myasthenia gravis will be involvement of the myoneural junction rather than the vagus nerve involved. Also, in case of a secondary metastasis, you can have a compression of the recurrent laryngeal nerve, and left recurrent laryngeal nerve will be involved very frequently in a person with a big left atrium compressing esophagus, trachea, left main bronchus and recurrent laryngeal nerve, left recurrent laryngeal nerve, and that is also named as Ortner syndrome, producing hoarseness of voice. And whenever a person is doing a surgery on trachea, esophagus, or block dissection or lymph node surgery in a neck, there is a very high chance of getting a damage to recurrent laryngeal nerve, because recurrent laryngeal nerve will be running in a carotid sheath. So whenever you are doing a surgery on a thyroid gland, parathyroid gland, on a carotid sheath, on internal jugular vein or common carotid artery, or a neck surgery, particularly lymph node surgery, etc., you can produce a damage to recurrent laryngeal nerve. And whenever you get a damage, it will produce dysphagia, hoarseness of voice, uvula will deviate to the non-affected side, that is normal side, and there will be loss of gag reflex as well as cuff reflex. All this will be the common finding. And particularly unilateral vocal cord palsy, you will have a hoarseness of voice, and you can get very frequently with bronchogenic carcinoma, big left atrium, particularly quite common with MR, and once in a while in aortic regurgitation. Also, along with aortic aneurysm, you can get left recurrent laryngeal palsy, mediastinal tumors like thymus, lymph nodes, or we call secondary metastasis, thyroid gland disorders can produce compression of the recurrent laryngeal nerve. And bilateral vocal cord palsy, we call aphonia, and this can be post-surgical, particularly in case of a thyroid surgery, parathyroid surgery, or if you are doing a surgery close to the trachea in carotid sheath, or on esophagus, parathyroid gland, block dissection, etc. You can have bilateral vocal cord palsy. Along with 9th cranial nerve and 10th cranial nerve, we go for the gag reflex. 9th and 10th cranial nerve both can be affected if we get the motor neurons of brainstem being damaged, like poliomyelitis, which can be unilateral or bilateral. Diphtheria can also produce unilateral or bilateral. Botulism can be also unilateral or bilateral. Guillain-Barré, pseudobulbar palsy. In pseudobulbar palsy, we'll have brisk reflexes, while in Guillain-Barré, we'll have a lower motor neuron type of palsy. Also, in case of a motor neuron disease, poliomyelitis, or we call bulbar poliomyelitis, this will be some of the other common disease which will be producing damage to the motor neurons of brainstem. In myasthenia gravis, we'll be having myoneural junction involvement and we'll have a muscle weakness. So person will have a ptosis with difficulty in swallowing, and sometimes person will also have difficulty in speech also due to involvement of pharyngeal, palatal and laryngeal muscles. We have already mentioned all those things. This is a part of the same thing, whatever we have mentioned in the previous slide. So I end my lecture here. Thank you for taking out time. I know that your time is valuable and I appreciate this for spending some of the time with me and listening to my lecture. If you feel this lecture is helpful to you, because once in a while you will come across a brainstem lesions or extramedullary lesion producing a damage to 9th cranial nerve or 10th cranial nerve, very frequently in a posterior fossa, tumors, etc. This will be helpful to you in your everyday practice. It can be asked in your oral exam as well as once in a while in your theory also. If you feel this lecture is helpful to you, please don't forget to press button like, subscribe, press bell icon so that you get an alert message. And if you feel your friend will be benefited, you can share with your friends. See you in next lecture.